First of all, I just need to say that I'm astonished that there's still anybody here. But thank you very much. I thought everyone would be up at Brown Thomas, up in Grafton Street. So I'm really grateful that there's somebody here. Okay, what I'm going to talk about is a piece of work that was published by NHS Scotland in 2017, just before I left to go and work at Queen's in Belfast. I'll tell you a bit about the assessment review process that we went through, the health needs evidence that we found, and what I think some of the and I think it fits really well with the last presentation that we've just heard. So, if I zoom back almost 20 years, I worked on the original health needs assessment that was done in Scotland back in 2004. It started in 2002, and Professor Anna Cooper, who will be known to some people at the University of Glasgow, chaired this process, and I managed it all. I then went on and did a whole load of other things, and at this time this review provided a very comprehensive overview of what the health inequalities were of people with learning disabilities. It was picked up on an international basis and attracted a lot of attention. So if we zoom forward to about 2016, the government in Scotland decided to integrate health and social care services. That's now happened, and there were concerns that the public health function of these integrated boards, who are responsible for all the population of their local area, including people with learning disabilities, weren't sure exactly what they should be doing in terms of strategic health improvement for people with learning disabilities. So, the wider context of this is that there's a growing international evidence base about the inequalities of people with learning disabilities. We've just heard some of it from the point of view of NHS England. We know that the population of people, children, adults and older people with learning disabilities is increasing, living into older age. So what we have is a population at either end of the age continuum that is increasing. So overall, there will be more people with learning disabilities and not less. We know that there's an increasing number of children and young people and young adults with neurodevelopmental disabilities such as autism spectrum disorder, ADHD, fetal alcohol spectrum disorder, now living into adulthood. Some of these people, as I'll show you, are starting to creep into our criminal justice services, and many of them are presenting with very complex physical, mental health and behavioural issues. There's a range of factors as to why this is. Neonatal intensive care improvement is probably the number one factor. Improvement to universal healthcare services, despite some of the challenges that we hear. Screening programs, immunisation, all of these are contributing to the improvement in life expectancy. However, as we know, life expectancy is still 20 to 30 years shorter when we compare it to people without IED. And this one, I think, from a public health point of view that we found is probably the most single important factor. The disease pattern that people with learning disabilities have is not the same as the general population. So what that means is we need to do two things. We need to do the same for people with learning disabilities that we do for everybody else, but we also need to do some special and particular things for them, because as I'll show you, the evidence is that the health problems that they have do not mirror that of the general population. And if what we want to do is decrease the health inequalities gap, then we have to take account of both of these concerns. Older adults with learning disability is the largest and fastest growing group within the learning disability population. So we're going to see more older people living into older age, many with a range of complex physical, mental and other concerns. So irrespective of where you work, whether it's primary care, acute care, specialist learning disability services, children's services, social care or education, you will come across more people with learning disabilities with very complex needs. So that's the wider context, which will probably not be a big shock to many people sitting in this room. So the report that we were asked to undertake was an update of the 2004 report. And because I had originally been involved and I was still in the system, I got asked if I would lead the update of the report, which we did from 2016 through to 2017. We were asked to provide an update of the research evidence base for policymakers, service planners, commissioners, funders and practitioners, and to provide an overview and an analysis and an interpretation of what the international evidence was from 2004 up to 2017. Dr. Maria Truesdale, who used to work at University of Ulster and now went to work in Scotland, and I undertook and led the review. And this is the reference for the report. So if you Google it, you'll automatically be able to access it as a PDF, which is free to download, and it gives you all the work. So we identified, reviewed and analysed and presented the published research from 2004 through to 2017, and we identified over 400 systematic reviews, meta-analyses, meta-syntheses, NICE guidelines and SIGN guidelines, which is the highest quality of research evidence that there is around the health needs of people with learning disabilities. So we sourced and pulled all those 400 individual studies and we analysed them, and they're clustered looking like this. So if I didn't have insomnia, I certainly did by the time we had finished this. I'm not going to talk about all of them. All of them are important. Every single one of them is important. The quality and the state and the volume of the evidence around each of these particular health conditions differs. The quality is greater in some areas than it is in others. And I've pulled out some of the ones that I think will be of interest to people here, just to talk a little bit about them. Unequivocally, in terms of the evidence, communication is the #1 recurring issue in the systematic reviews that we were able to source in relation to expression, comprehension and confidence in the ability to communicate your health needs. Probably over 90% of people with learning disabilities have some kind of difficulty and issue in doing this. And if you think about the presentation that we've just heard, the minute you access healthcare systems, you have to give information about yourself. And if you have issues about communication, comprehension, and confidence in doing that, you're automatically disadvantaged within the healthcare system. The research evidence relates to the barriers regarding assessment, diagnosis, and investigations and treatment that will be necessary to avoid premature mortality and death. And what the evidence tells us is that all people with learning disabilities, irrespective of the conditions that they have, will be high and frequent users of all our universal health service. The universal health services that are available to every single one of us, so primary care, community health, unscheduled care, telehealth. And if we think recently over the past decade, we have seen monumental changes in the way in which universal health services are delivered and accessed for all of us. And I would say that the evidence isn't clear as to whether this disadvantages people with learning disabilities, but if you think about the way you access healthcare systems, we need to think when we redesign them about some of the most vulnerable people who will access them. We heard a little bit about the respiratory disease. I may have one or two solutions about how we may prevent some of this. Leading cause of death for people with learning disabilities, and it's the second commonest cause of death in the general population. So a difference there. Cardiovascular disease is a common cause of death in the general population. So swallowing and aspiration problems are the #1 problem, linked to chest infections with aspiration. We identified systematic reviews that looked at the pathogenic oral microorganisms that are living in people's mouth that cause dental caries. And there seems to be a link between poor oral health and poor oral hygiene and dental care and fluid intake that relates to chest infections. So these microorganisms living in between teeth, on your tongue, and people with swallowing disorders are then inhaling infected saliva down into their lungs. This is what we found in terms of the research studies. So some of these solutions are about fluid intake. about good oral care, about good dental care. And if you think how much it costs to make sure that people have good oral care, it doesn't cost much. So some of the early preventative things, picking up Gwen's point there, may be something that we can do as learning disability nurses to try and prevent some of these issues even from occurring. Respiratory cancer at the moment, which is common in the general population, seems to be lower. The evidence is that people with learning disabilities, apart from those with very mild learning disabilities, tend not to smoke. So therefore, respiratory cancer tends to be, but not exclusively, linked to smoking. But as the population ages, will we see more people with respiratory cancer as they age, which tends to be associated with older age? Asthma is linked to obesity in people with learning disabilities, and we know that this population is obese with poor diet and poor physical exercise. And there was some evidence about enabling people with learning disabilities to access stop smoking programs, but additional support is required. So that was some of the respiratory issues. The cardiovascular, second commonest cause of death. 14% of people with learning disabilities experience some form of cardiac issue. Higher in women, higher in the elderly, and higher in people with mild learning disabilities. People with learning disabilities more likely to be obese, to have high blood pressure, and to be physically inactive. Congenital heart defects common in people with Down syndrome. These will be lifelong, so there'll be need for intervention across the life course as people with Down syndrome age. Increasing and aging learning disability population means, will we see more cardiovascular disease as people with learning disabilities age? And a couple of Dutch studies that have been done looking at metabolic syndrome in people with learning disabilities, very common in the general population. It's a cluster of 5 symptoms that lead to metabolic syndrome, and it can be preventable with early intervention. And the Dutch study found it was 25% higher in people with learning disabilities when compared to the general population. So some issues there for early intervention. Epilepsy, the most common comorbid health condition experienced by people with learning disabilities. If you have a room full of 100 people from the general population, 1 to 2% of them will have a seizure disorder. People with mild learning disabilities, it's 22%, and this rises to about 60% in people with very severe learning disabilities. So epilepsy is very common. 12% prevalence rate in people with Down syndrome, and the prevalence of epilepsy and Down syndrome increases with the prevalence of Alzheimer's in people with Down syndrome. So as people with Down syndrome are living longer, we're seeing more seizure disorders in them. Prevalence of about 31% of seizure disorders in older adults with learning disabilities, linked to complex seizure types. People with learning disabilities do not present with simple tonic-clonic seizures. They all present with multiple complex seizures, which means that they will depend upon polypharmacy, multiple drugs. When we think about the causes of the mortality and what may lead them into our general health services, accident emergency, often it will be epilepsy, falls associated with seizures that result in soft tissue injury, fractures, head injuries, which then lead to the need to access general health services. Sudden unexplained deaths. There is a couple of systematic reviews been looking at the prevalence of this, and again, it'd be interesting to see as the work in England starts to unfold to what extent this all plays a part. There's one study that we found, one systematic review, looking at the link between epilepsy and neuropsychiatric morbidity and mood disorders in people with learning disabilities. So that may be a kind of area that people are starting to have a little bit of interest in. Cancers, at the moment, the evidence is that the overall incidence of cancer in people with learning disabilities is lower than for the general population. We know that children and adults with Down syndrome are more likely to experience leukemia and lymphoma, which is cancer of the white blood cells. Testicular, pancreatic, ovarian, uterine, retinoblastoma of the retina of the eye are all common in people with Down syndrome, so a different cancer profile there. And we know that the cancer profile is different in people with learning disabilities at the moment, with esophageal, stomach and gallbladder cancers being the most common, which is different from the general population. So again, if you look at your cancer strategy, which is aimed at the general population, and it doesn't pick up some of these distinct differences in people with learning disabilities, we're going to miss some of the cancer in them. And gastrointestinal cancer is the most common at about 50%. And there's some evidence emerging about barriers to accessing national screening programs, cervical, breast, bowel screening, all aimed at the general population, are more difficult, which may account for some of the reasons why people with learning disabilities present later for cancer screening and cancer care. Mental illness is very common in people with learning disabilities, children, adults, and older people. We tried to find out studies to look at the exact prevalence rate. It seems to be sitting about 36 to 40% of people with learning disabilities is a lifetime prevalence, which is high. Anxiety disorder is the most common psychiatric illness in people with learning disabilities, followed by depression. Depression is most common in the general population, so a slightly different presentation there. Anxiety disorders and depression are more common in people with Down syndrome. Schizophrenia, probably about 3 times more common in the learning disability population. Also increased risk of post-traumatic stress disorder. Some studies starting to look at issues like abuse, adverse life events, and a couple of systematic reviews looking at loneliness and social isolation in aging people with learning disabilities, where family and kinship networks, as people die, are lost and people are go into some kind of supported care. So that's something I think that may cause PTSD. The diagnosis can be a challenge because of communication, access issues, polypharmacy, particularly common in people with learning disabilities. They're probably the most medicated population in the whole world. So they'll be having medications for epilepsy, anxiety disorders, depression, gastrointestinal problems, a whole range of conditions. And studies done here as part of Professor McCarran's work looked at the polypharmacy profile of large numbers of people with learning disabilities. We found limited evidence regarding psychological therapies and people with learning disabilities, despite programs about improving access to psychological therapies. The only evidence at the moment for CBT relates to anxiety disorders. That's it. There isn't anything else. But there is work currently getting done. There's research looking at trauma-focused CBT, EMDR, range of different things. So I think that will gradually change. And we have barriers because of the limitations in the evidence base regarding the benefits of psychological therapies. Challenging behaviour is very common, as people in this room know. Probably a prevalence of about 10 to 15% of people with learning disabilities will experience a challenging behaviour at some point in their life. Peaking, highest prevalence rate around the age of 29 to 30. The range of challenging behaviour issues in terms of the evidence: aggression, self-injury, stereotypical behaviour, agitation, withdrawn behaviour, arson and sexual misconduct. Some evidence, which is quite well established and isn't particularly new, Prader-Willi syndrome and Lech-Nye syndrome has a challenging behaviour profile attached to it. Evidence emerging about the benefits of positive behaviour support models, which need to be embedded in all our care services. Some evidence about psychosocial interventions, behaviour interventions. And if anybody was about last week and watched the BBC Breakfast, there was a whole focus about the STOMP work. Really, basically, we took a lot of time to look and see what is the evidence about the use of antipsychotic drugs for challenging behaviour, and there isn't any. And yet it's a huge problem. So I think that is not having them prescribed in the first place and having access to evidence-based alternatives is the key there. As people with learning disabilities age, we're seeing they're at higher risk of Alzheimer's. That's across the learning disability population. Dementia, Alzheimer's, dementia being the most common. Dementia occurring in people with Down syndrome 20 years sooner, 20, 30 years sooner than the general population. If you're a person with Down syndrome at the age of 50, 30% of them will suffer from Alzheimer's. If you're a person with Down syndrome at the age of 60, it rises to 80%. So as this population ages, we're going to have to care for large numbers of people with Down syndrome and other learning disabilities with Alzheimer's. So we need to think how orientated and well able our care services are. Some evidence, some studies looking at your anticholinesterase drugs for early prevention of Alzheimer's. Health checks, there's actually some pretty good evidence now that even there's well-established evidence about the health profile of the physical mental health conditions, barriers to accessing health assessment, preventative care and interventions that are available to the general population. Evidence about the low uptake of national screening programs that are targeted for the whole population, and evidence even targeting people for health checks and inviting them in brings about positive health gains. Some countries in the UK have funded health checks within primary care, and these health checks, there's evidence about the benefits of focusing on immunisation, cancer screening, disease detection and so on, and very clear evidence about the unmet and unrecognised health needs. So what do we think this actually means when we were asked to take a look? I've then tried to link it to what I think this means for our practice as we move forward. I find it astonishing, these conversations taking place, I must admit, across NHS England about the viability of programmes within HEIs. Could you imagine this scenario that I'm going to give to you? They said, oh, last year we delivered 100,000 babies, and this year we're going to deliver 200,000. Let's decrease the number of trainee midwives. The conversation would never happen. Could you imagine saying in a paediatric intensive care unit, we don't need skilled paediatric nurses because we taught the mums and dads to care for them at home, so they're going to do a rota and come in and run the neonatal intensive care unit? Oh, let's train the social care support workers to deliver the babies. The midwives can do the housing assessments. And the midwife can be on call to give the social care support worker advice to catch the baby. The conversations would never, ever happen. And yet here we have evidence of a population that is increasing, that is aging with more complex needs, with high mortalities or preventable causes of death, in need of early interventions from skilled, knowledgeable practitioners, and we do not have the wherewithal to say our commissioning for the workforce is actually flawed. Anyway, what I think this means, and please quote me on that, I'm happy to be quoted, increasing number of children and young people with multiple complex disabilities, physical and mental health needs, key area for learning disability practice. CAMS LD services are being well established. We're now seeing services within adult services for children with life-limiting conditions who are becoming adults, where they need portable ventilation, tracheal suction, all those kind of conditions. We need more of these kind of services because the prevalence rate of these children is increasing and they're living into older age. Even though older age is still markedly shorter, I think now there is clear international evidence. We reviewed 400 systematic reviews of the research studies of the evidence regarding the health needs and the inequalities and the different health pattern and health conditions experienced by people with learning disabilities. This needs to be central to guiding our practice because it gives us a very clear steer on where we should prioritise our expertise and our skills. We have an increasing and ageing population of children, adults and older people with more complex, interrelated physical, mental health needs. Very clear roles there for learning disability nurses. Increased access to universal health care is a significant problem. Again, key role for learning disability nurses about equality of access, equality of health outcome, and the reasonable adjustments that need to be made to enable individuals to access healthcare. There's good evidence about systematic health screening programs, health promotion, health education. First of all, for people with learning disabilities themselves, to help them to self-manage some of the health conditions that they've got. For the family carers, and I think a massive role for learning disability nurses is for our social care support workers, who are often being asked to do very challenging jobs with limited education and knowledge, so a key role there. Increasing population of older people with learning disabilities, key area for learning disability nurses around dementia care, comorbid psychiatric issues, behaviour issues, end-of-life care and decision making for people with learning disabilities themselves, but for their family members, key role for us there. People with learning disabilities accessing universal health screening programs, how do we enable equality of access for them? High prevalence of psychiatric illness and offending behaviour in people with learning disabilities, now seeping into our criminal justice systems. Will we see more, if we're going to see more people with ADHD, fetal alcohol spectrum disorder, mental illness, challenging behaviour, impulsivity, assaultative behaviour, they will come in touch with our criminal justice system, and the question is whether prison is the right place for them. Key role for nurses who work with people with learning disabilities, high prevalence of challenging behaviour with people in need of access to skilled behaviour support teams with learning disabilities at their heart. I could go on, but it is Friday. So, just so that you know, the Nursing and Midwifery Council, I think in May, I think at long last, are going to publish the new nursing midwifery standards. NMBI published their standards previously. The programmes in the Republic are going through the validation process now. What an opportunity to design programmes based upon evidence like this, so that we can ensure that the standards that we're applying across all fields of practice, because we do need our general nurses, our mental health nurses, our children's nurses to have some knowledge and skills more than they do just now around people with learning disabilities. A piece of work I did a long time ago for the government in Scotland and the Chief Nursing Officer was to look at the countries across the world where they had moved to a generic field, programme. When you look at Australia, New Zealand, South Africa, America, all of them were promised that mental health and learning disabilities would be core to generic nursing programs. And guess what is not core to these nursing programs? Mental health and learning disabilities. And I was watching the tweet feeds just very recently about we need to revisit generic nursing in the UK. I'd be all for generic nursing if the programs were designed around the needs of people with learning disabilities first. Wait till we see if that one happens. New standards to prepare nurses to work more flexibly across all care settings. People with learning disabilities are in all places, so we need to ensure that the nursing workforce has the knowledge and skills to follow people with learning disabilities. We need to be able to manage care for people with multiple complex needs. I think that's what we do best, because we work with large numbers of people with learning disabilities with very, very complex needs. The new standards are going to maintain at the moment entry to adult, child or general nursing, mental health nursing and learning disabilities. It's the same here in the Republic. As long as my career has been about, every decade roughly this resurfaces. Do we need them? What do they do? Will it be generic? It will be embedded in generic programs. We'll love all of you and it'll all be fabulous. The new standards are linked. If we link these new standards to this health needs evidence, I believe it's the perfect opportunity to build a creative and innovative learning disability nursing programme for the future. So I would make a plea to England to catch up and rethink what they're doing. So implications for learning disability nursing as we nearly finish: increasing life expectancy, more people living into older age. There's going to be more demands for education, health, social care and housing support in all different kinds of service models because the population is going to require it. Significant health inequalities still exist with multiple comorbidities, a key role for us. Specific health needs in a different pattern, which we need to educate people about. I think If this is not an agenda that requires knowledge, skills and expertise from learning disability nurses, then I do not know what agenda does. I do not believe that if we do not need nurses to work specifically with this population, we don't need registered nurses at all. I would go that far. So how do we enable, as learning disability nurses, access for people with learning disabilities to universal health services, assessments, intervention, treatment throughout the whole care journey, particularly into acute care and then back out? Access to support and education for universal health services, early intervention, development of more specialist learning disability services for people with multiple complex needs, because we're going to need experts, true experts, around many of these things, so that we can then have an evidence-based service. So, are there opportunities for learning disability nurses in the future on the basis of this analysis of the evidence? If we can't see it, we should pack up and go home. I believe there's an increased demand for knowledge and skill of learning disability nurses, opportunities that we can lead the changing landscape of care for people with very complex needs. We can provide care at all stages across the lifespan. We can lead services. We can look at models of care that meet needs of people with multiple complex care needs. We're already doing many of these things, but we need to do more. I think there's a very clear need for higher level clinical nursing skills for people with learning disabilities around therapies, interventions, and the proficiencies within the nursing teams need to be improved to deliver care for people with very complex needs. Learning disability nurses playing a key role in leading services, coordinating care, providing nursing care that's evidence-based, that's compassionate and tailored to the needs of the individual, their families, and a key role, I believe, for working with social care support staff to support and to educate them. Key roles around health assessment, health promotion, health education, health interventions to help improve health for some people and to maintain it where we possibly can, educating families, skill sharing to enable health inequalities to be reduced, flexibility of how we use the nursing workforce to work across care services where people with learning disability need them, and then how do we support learning disability nurses to be resilient, emotionally intelligent to deliver services for the future, I think are some of our challenges. So, some areas where we may have to, I think, complex care needs for people with physical needs, increased training around behaviour therapy, liaison nursing roles, substance misuse, develop and identify leaders, educators and researchers for the future. You all look absolutely amazing and stunning, but some of us are not as young as we used to be. Develop new research partnerships between the universities now so that we can grow this evidence base. How can we have learning disability nursing programs that draw on this evidence base so that the practitioners are fit for purpose for the future? Are there opportunities? We have really fantastic, bright, able students. Should we be collaborating across universities to get people into doctoral programs at a very early stage so that learning disability nurses are providing the solutions for their practice? These are opportunities there. Erasmus programs, shared education, international shared learning and joint academic appointments so that our students are getting the opportunity to work nationally and internationally. And there we go.